listen-only mode.
So good morning and good afternoon and good evening and so on to everybody. This is Birger Forsberg. I'm at the Karolinska Institute in Stockholm, and just hold your breath while we are getting people to enter our webinar here. It will take a few seconds, maybe up to 60. Okay, more people coming in. Very good. Okay. Thank you very much for joining us, and I think we can start to move here as we have an intense hour ahead of us. And I'll say then welcome to everybody, and start by just saying that we are going to share this webinar where we're going to present you some findings, results from scientific research. Maybe we can get the next slide. Which is based on a special supplement in the Journal of Health Policy and Planning from July of this year. And this is in its turn based on presentations given at a symposium in Toronto in 2011, from which we invited everybody to submit papers, and then the best were selected for this issue. And you can find those articles and the whole supplement at either of the websites which are given here on this slide. Next slide, please. Okay, so our lineup today is a group of 5 researchers. Lucy Kanya, she is with the Population Council and currently in Nairobi. And David Hotchkiss, who is at Tulane University in New Orleans. That is today, and Ilana Levey, who is with Apt Associates and Gallup, currently in Washington. And we have Meenakshi Gautham from London School of Hygiene and Tropical Medicine. She works also a lot out of Delhi, where she is today. And finally, Amanda Pomeroy from John Snow Incorporated. She is in San Francisco. So we have quite a geographic spread here. And next slide, please. Okay, so you will all be invited to ask questions as we go along, and there are 2 options: written questions, and those can be written by using the question box in the GoToWebinar control panel at the right of your screen, and that's our preferred mode as we give our presentations. There is a second option, which is oral questions, and you can raise your hand by using the button in the GoToWebinar control panel. There's a small hand up there on, at the top, and the organizer will then unmute your microphone. That's more suitable for our general discussion towards the end of our webinar. So in order for us to all to benefit from the presentations, it's better to go through them first, and then, as I said, either write your questions as we go along or take notes of them and then ask them orally. Okay, I hope everybody is on board and ready to go. Our first speaker is Lucy Kanya, and I'll turn over to her then.
Next slide. Hello, everybody. My name is Lucy Kanya from the Population Council office in Nairobi, and I'll talk to you today about the Safe Motherhood Voucher program coverage of health facility deliveries among poor women in southwestern Uganda. Next slide. Next slide, please. Next slide. So Uganda, our country of focus, is has a high maternal mortality rate with 438 live births out of 100,000. Out of this, 95% of pregnant women attend at least one ANC visit. And with this, we have a very low uptake of facility-based deliveries at 57%. And we have wide economic disparities in the use of health services. largely due to limited availability, accessibility, and the perceived low quality of healthcare services. Next slide. So the focus of this, and which is what I'm going to build my analysis and my talk on, is government spending on, or total health expenditure on health. So the government spending on reproductive health in Uganda is at 4%, with households contributing the large share of reproductive health spending in Uganda at 72%. And this high out-of-pocket spending, it revolves around 9% of household expenditure on health, with 4.8% of households have catastrophic health expenditures on average, and 2.3% of households are pushed into poverty, largely due to medical bills annually. And this is from the National Health Accounts, Uganda. Next slide. Next slide. Next slide, kindly. Next, thank you. So the voucher program, the Uganda RH Voucher program began with a pilot in 2006 to 2008. But the focus of this is a period 2008 to 2012, where the program expanded to include a healthy baby voucher, in addition to an existing healthy life voucher. And this is happening in 20 districts in southwestern Uganda. So the program is funded by KfW, the German Development Bank, and with additional funding from the Global Partnership on Output-Based Aid of the World Bank. Next slide. And in this, I just show our voucher sites in Uganda. So the yellow bullets that you see is a map of our distribution sites for the Safe Motherhood Voucher program in Western Uganda. So the program covers the whole strip in southwestern Uganda, but with a focus in only 22 districts. Next slide. So just a little on the voucher program design and functions. And in this we have three major things to think about. The voucher management, which is Maristops Uganda. We have our facilities, and we have 94 accredited private facilities purely, who get reimbursed for ANC delivery services, including surgery and referral if necessary. And then we have a client who is assessed using a poverty grading tool. And once the poverty status is assessed, then they can buy the voucher at approximately $1.50, which is equivalent to waivers for anyone who truly cannot afford to purchase the voucher. Next slide. So the program evaluation is done largely by population councils, and this is aimed at assessing the program effects on the impact on improving reproductive health behaviors, the effect on improving access, the quality of RH services, effect on reduction in out-of-pocket expenditures, costs, and lastly, coverage, which is what I'm going to be talking about. Next slide. In my coverage analysis, I want to look at the extent to which the program has succeeded in reaching the target population in Uganda, which is our poor mothers. Next slide. Next slide. So in this, I'm looking, we analyzed 2010 voucher claims data, which we got from the Voucher Management Agency, which is Maristops International. And in looking at our coverage estimation, we are looking at the proportion of safe motherhood voucher deliveries as a proportion of the general population, and the proportion of safe motherhood voucher deliveries in the poor population. Next slide. So for general population estimates, we used the 2010 UBOS, that's the Uganda Bureau of Statistics population projections. And in this, we assume that the population growth rates remain the same over the period. And the poverty indices, again, that we use in this estimation were also obtained from the same study, the UBOS 2010. And we used national crude birth rates from the DHS 2011. Lastly, with all this, we estimated coverage of the voucher program in our target districts for the year 2010. Next slide. So I quickly just focus on the three major findings. The first one is that the voucher program actually did pay for 38% of estimated deliveries among the poor population in the target districts. And secondly, we had a significant negative correlation between poverty density in a district and the proportion of births covered by the program. And lastly, we, from the study, we see that improving voucher coverage among poor women is dependent upon, improving coverage of the program among the poor women is dependent upon increasing both voucher sales and redemption rates. Next slide. Next slide, please. So what does this mean? We've seen from other studies that the program does stimulate demand for safe motherhood services among new users. And by new users here, I mean mothers who've never used a facility before or mothers who did not use a facility for the previous delivery. So then with this in mind, given the shift from home to facility deliveries, and secondly, the ability of the voucher program to cover a significant proportion of deliveries in the region, then we are seeing that the SM voucher is capable of accelerating uptake of critical safe motherhood services, and this would help to move the country towards universal coverage of maternal health care. Next slide. It would also help generate much needed revenue for health facilities in Uganda. And we are saying in conclusion that supply and demand side approaches do need to be complementary. So contracting could expand supply of appropriate care. And in contracting here, we are talking about expanding the program beyond private providers to include public providers, who would then increase the geographical coverage of the program. And subsidies are best targeted to individuals who, in the absence of the subsidy, would have failed to use the service altogether, or individuals who would not have used the health facility. So then lastly, there's need to implement these voucher programs within the broader health system context, because as we will see, and as we've seen from other studies and also from this study, there are issues that the voucher program in and of itself cannot address, which would only be addressed within the broader health system issues. And I end my slide with that, and I would like to invite David from Tulane University, who's the next presenter. Thank you.
Okay, thanks, Lucy. This is David in New Orleans. This paper is looking at private sector provision of institutional delivery and horizontal inequity, and we're looking at two countries, Nepal and Bangladesh, and I want to acknowledge my co-authors, Dipali Gadye at Futures Group and Mai Do, who is one of my colleagues at Tulane. Next slide, please. Just by way of background, despite some impressive progress in recent years in a number of different health outcomes, wealth-related inequities in service use continue to be a large problem. In most countries, rich-poor inequities are actually greater for maternal health care services than for other services prioritized by governments, including newborn and many different kinds of child health services. Next slide. Well, one strategic approach to increase the use of appropriate healthcare services, including maternal healthcare services, is to encourage the expansion of the role of the private sector. And potential benefits include improved efficiency, improved mobilization of private resources, and also the potential for improved targeting for the poor. However, there are critics of a private sector-based approach. They argue that the increasing role of the private sector may limit financial access, may not serve the needs of the poor, and may actually increase inequity. Next slide. So this paper, what we did is we explored whether the expansion of the private sector in two countries where the private sector has expanded is associated with an increased wealth-related inequity in facility-based delivery assistance, and we chose Nepal and Bangladesh, although as you'll find out later, these really focused on two different kinds of strategies. In both countries, maternal mortality has been high, and the percent of the women who are delivering at facilities is low, but it's been increasing quite rapidly in recent years. Next slide. In terms of the methods, the study is based on multiple rounds of demographic and health survey data collected in Nepal and Bangladesh over a period from 1996 to 2011. You can see the survey years in the slide. The unit of analysis is women who delivered during the 3-year period before the survey, and we analyzed shares in the share of deliveries in a private facility, and that's defined as either being for-profit or an NGO facility, a public facility, and at home by wealth quintile. And then to look at inequity over time, we calculated concentration indices for each survey round and then compared those indices across rounds. Next slide. Just a few results. In Nepal, this is just showing the overall share of women who are delivering in public and private facilities. And you can see that although the private sector has been expanding, the public sector has been expanding at a much greater rate, especially since 2006. And that's most likely due to Nepal's free delivery policy, which was introduced in 2009, and that's aimed to reduce the cost of delivery care using a lot of different approaches, but you can read more about that in the paper. Next slide. In the Bangladesh, the situation is quite different. The private sector has increased much more rapidly, especially since 2004, and so it's actually a more important source of facility-based delivery than the public sector. Next slide. We looked at the results by wealth quintile, and the next two slides show this, and you can see that in Nepal, the percent of poor women delivering in private facilities has increased, but it's still relatively small, and in all wealth quintiles, the public sector has increased more. Next slide. In Bangladesh, it's a bit different, as indicated by the last slide, and it's interesting to note that by the time of the 2011 survey, for all wealth quintiles except for the very poorest wealth quintile, again, the private sector is a more important source of delivery care than the public sector. But again, the poorest group of women are relying heavily on the public sector. Next slide. I also didn't mention the concentration indices, but overall the results showed that wealth-based inequity decreased as the role of the private sector increased, but there were significant drops in inequity in both countries despite the different approaches that the country has taken. In Nepal, the public share rose much faster than the private share, most likely due to the free delivery policy. In Bangladesh, there was a heavy emphasis on NGOs as the important provider of maternal health care. In terms of equity, the more privatized system of Bangladesh performed actually similarly to that of the more public system in Nepal. Next slide. Implications, this suggests that within mixed health systems, the private sector can play a greater role in maternal health care services, without necessarily leading to inequity, and in fact it can actually play a role in improving equity. And of course, the proper role of the private sector does depend on a lot of different governance factors, the government stewardship ability, the health financing situation in the country, and then the organization of the private sector. I'm going to skip the next slide, and I'm going to hand it over to Ilana.
Thank you so much, David. Thank you for this opportunity. I'm going to be talking about a study that I conducted while I was at Apt Associates and currently at Gallup, looking at the quality and utilization of HIV counseling and testing services offered by the private sector in Zambia. This research was funded by USAID through two projects, SHOPS and the Private Sector Partnerships 1 project. So in terms of context, Zambia has a high generalized HIV epidemic. It also has a growing private for-profit sector concentrated in urban areas. But there's a lack of evidence about the quality of counseling and testing services in the private sector. In Zambia, HIV counseling and testing is offered in 4 sectors: in the public, private for-profit, NGO, and faith-based or mission sectors. And there's been evaluations that looked at quality particularly in the public and NGO sectors, but not broadly across the health system. There is very, very little evidence, though, about the quality and the role of the private for-profit sector in offering counseling and testing. And of course, the quality of counseling and testing services affects both HIV prevention and treatment outcomes. Next slide. So this study used mixed methods to assess quality, both qualitative and quantitative. We used close-ended client intercept interviews with clients who had received HIV counseling and testing. We also did an open-ended exploratory interview with those clients. We interviewed facility managers at all sample sites, both with close-ended and open-ended questions. We did a review of service statistics for counseling and testing for each sampled site. and we observed the physical environment for counseling and testing in all of the sites to put together a robust picture of quality. This is a look at the characteristics of the sample for those clients who received an HIV counseling and testing session on the day that we visited facilities. We focused on 2 provinces in Zambia, Copperbelt and Luapula. So these results are generalizable to the provincial level using probability proportional to the size sampling. These are the sampled sites where we have client data. The paper in the supplement also presents facility level data where there were no exiting clients who had received HIV testing. In that facility level sample, there's an additional 14 private for profit sites. But overall, you can see that in the Copperbelt, we had a strong representation of private for profit sites where clients received a test. In Luapula, which is rural, not so, and that makes sense given the distribution of private sector sites. Next slide, please. So one dimension we looked at was how the private sector compared to the rest of the health system in some important dimensions of quality for HIV counseling and testing. And I just wanted to show you some examples. One thing we see is that there are no clear patterns between the sectors, but the private sector performs on par or better than certain sectors in some important elements, including did your counselor on the day of interview answer your questions about your HIV test and counseling session with enough detail? Also, did your counselor provide clarity about what your HIV test result means? So we think that that's pretty noteworthy given how little investment there had been in training private for-profit counselors in HIV counseling and testing best practices and incorporating them into national HIV prevention efforts. Next slide. Very interesting to us was, again, this element of no consistent patterns in quality across all 4 sectors, but the analysis revealing really striking underperformance in quality in some key areas. So we asked exiting clients to tell us what methods were discussed with their counselor during their HIV counseling session after they had received their HIV test result. And as you can see, disclosing their test results to their partner, which is a very important best practice in HIV testing, had extremely strong underperformance across all of the sites. Additionally, partner reduction, or reducing your number of partners based on your HIV test result and counseling session, also had strong underperformance. So we're not getting a picture of the private sector performing worse than the other sectors on these key dimensions, but we're seeing underperformance across the board. Next slide. The qualitative analysis was really interesting. We asked these clients who had just received an HIV test and counseling session what topics were covered in their counseling sessions, and we asked them to tell us in their own words unprompted. And we saw that across the sectors, many clients reported hearing emphasis on minimizing blood exchange, avoiding sharing of needles or sharp objects, which is interesting given how the epidemic in Zambia is transmitted largely through sexual activity, not through blood exchange. So it really looked like a disconnect between the information that they were receiving and the epidemiology of the HIV epidemic in Zambia. On the positive side, across all of the sectors, we had strong emphasis on living a positive life as an HIV-positive individual and optimism around treatment, but less emphasis on risk reduction and prevention of future transmission. Next slide. So what are the key messages emanating from these findings? Firstly, we wanted to know how does the private sector compare in quality to the other sectors in the health system, and we saw that the private sector performs on par with the other sectors, and there's high performance on some key variables of quality. We looked at why clients chose one sector over another. Those results are presented in the paper. where geographic proximity was more important than price or perceptions of stigma in choosing a type of site. Overall, we saw that all sectors are underperforming in key risk reduction elements, including counseling on partner reduction and disclosure of results to partners. And overall, worldwide quality of HIV services in the private for-profit sector, particularly around counseling and testing, continues to be under-researched. So with that, I'm going to pass it over to Meenakshi, who's from the London School of Hygiene.
Thanks, Ilana. And hello, everyone. I'm at the London School, but I would like to very gratefully acknowledge the work on this study, which I'll be talking about, by many of my Indian associates at two organizations, Crinio in Chennai in India, in the south of India, and the Garhwal Community Development and Welfare Society in Uttarakhand state in the north. And we have a website on informal providers as well as an e-discussion group. I'll be talking a little bit about the overview of informal providers and then focus on my own study. Next, please. We know that in low and middle income countries, the health system is characterized by mixed public and private healthcare services as well as financing, and the private sector often exceeds the public sector. And you can see it ranges from 79% in South Asia to 50% in Sub-Saharan Africa. Next, please. This is more specifically from my country and from one of the most populous states in India called Uttar Pradesh, short for UP. This is data from the annual health survey, which shows that very few of care seekers for acute illnesses, only 5.4% of care seekers for acute illnesses sought care from government sources, and 15% of care seekers for chronic illnesses were getting regular treatment from government sources. The rest all from the private sector. Next. So what does this private sector consist of? It's not made up of all formal qualified physicians, and this particular study, which I have quoted here, has demonstrated that when the private sector included unlicensed physicians, it was found to provide the majority of coverage for low-income groups, but when only licensed providers were included, the public sector was found to be the main source of healthcare, which shows that a very large proportion of providers are actually unlicensed in the private sector. Next. So we also have begun referring to these unlicensed providers as informal providers. There has been a review done on informal providers by some other authors quoted here, and they've worked out some definitional criteria which we have also used in our paper. So they're defined by informal training, providing a fee for use from the patients. They are not registered, typically not regulated, and rarely have any professional affiliations. Next. And they may include drug sellers who are operating beyond their capacity. They may include all kinds of village doctors, traditional practitioners, TBAs, community health workers performing beyond their scope of work. Next. But the largest majority are those who provide some kind of health care in return for a fee, and they provide some kind of allopathic treatment, and the extent of these varies from about 87% in Bangladesh, 96% in one particular block of Bangladesh called rural Chakaria. India, about 55% of all providers are informal, Uganda 77%, so it's a really huge population. Next. So coming to our study, yes, so these are utilization figures which are also very high. They are usually the first point of contact for all common illnesses, especially for poor and rural households. Next. So our study was done in two districts, in two different parts of India, in Tehri Garhwal in the north and Guntur in Andhra Pradesh state in South India. Next. The two districts are very different, and these pictures show the differences. The top picture is of Tehri district, and you can see it's very, very rural, not very well developed, not too many roads, whereas the one in the south in Andhra is has better roads, and it's also got more medical colleges, interestingly. And the infant mortality rates also differ between these two districts, 61 in Tehri and 49 in Guntur, which is the district in the south. Next. So we found informal providers, the kind I talked about, in both these districts. And these two graphs show the coverage of informal providers compared to private doctors and public doctors per 100,000 population. The blue bars represent informal providers, the red bars represent public doctors, and the green bars represent private sector doctors. And you can see that in both these districts, the informal providers are providing a much higher coverage to the population than the qualified doctors, public or private. We had also looked at this coverage across blocks with different levels of indices. In India, districts are divided into blocks. So we had clustered blocks with varying levels of development into low, medium, and high development block clusters. And you can see the results over here. Interestingly, we found that in Tehri, which is the more poorly developed district, informal providers as well as public sector doctors were the greatest in the highest development blocks. But in the other district, in Guntur, we found that the proportion of public sector doctors was quite low. The informal providers were the highest in low development blocks, and we found that the number of private sector doctors as a proportion of the population was also much higher in Guntur district, perhaps as a result of the number of private medical colleges over there. But essentially what this captures is that informal providers are already covering the population much more than qualified providers are. Next, please. There were a lot of differences between informal providers in both the districts, just showing that these were two very different markets catering to a very similar health need. So we found that in the north, they actually had a higher level of education, both in terms of schooling, in terms of having college, having studied up to a graduation level, having some kind of a health diploma or certificate like in pathology or pharmacy or something like that, whereas in the southern district, there were very few of these diplomas, but the majority over there had learned as apprentices with other qualified doctors. And the number of years of apprenticeship also varied. It was much more in the south as compared to the north. Next. The unique feature of IPs in both the districts was that they were part of the community where they practiced. They were either born in the same block or in the same district, and that is a real key feature of why they are accepted, why they are able to work in those surroundings. Next. Another key feature of their services is that they provide doorstep services almost. Whether it is, it can be through mobile-based care in the southern district in AP, or it is through clinic-based services in Uttarakhand. They are much more accessible, much more available, and the key to their acceptance and popularity is proximity. I won't go into details of this, but you can see these in the paper in the Health Policy and Planning Supplement. Next. So we looked at their knowledge levels because we expected that with their difference in educational and training backgrounds, we might find some difference in their understanding of the management of three key conditions: fevers, diarrhea, and respiratory conditions. But we actually found that there was very little difference, and they had reasonably high knowledge levels, you know, between, you can see between 67 and almost 80% for diarrhea. So there were no significant differences between the two sites. Next. We looked at performance by observing actual patient-provider interactions. I'm not going into details of the methods because this is all very well described and detailed in the paper, so you can read it over there. But what we found was that yes, performance was not as high as knowledge, but still there were very few differences between the two districts, and that was again very interesting for us because we expected one or the other district to show better performance. Next. The big difference that we found was in their drug use, in the medicines that they were dispensing, especially the injections that were given. We found that in the southern district in Guntur, the percentage of patients that received an injection was a very high 71%, whereas in Tehri it was only 13%. Mean number of antibiotics was also more in the southern district, and the percentage of patients that received 2 or more antibiotics. So in the south, they were definitely dispensing more medicines, and we found, this is again very interesting. We found that we expected that the main source of new knowledge for the IPs would be something like medical reps and all, which is commonly assumed, but it was actually qualified doctors. That orange bar stands for qualified doctors, and we found that the majority of IPs in Guntur said that their main source of knowledge was from qualified private doctors with whom they had good relationships. Next. I'm sorry, these slides are not turning for me. Okay, so very strong relationships, not just for exchange of knowledge, but also with respect to receiving and sending referrals and receiving commissions. But in the north, it was very different. There was much more hostility between qualified doctors and the informal providers. Next. Next. So in the this is another very interesting finding, that in the southern district, the informal providers are very strongly associated in district level associations, and then at the state level in a state level federation. And a few years ago, they very successfully lobbied for greater recognition for themselves and worked out a training program, a one-year training program, along with registration with the paramedical board in the state. Next. This was spearheaded by the chief minister of the state at that time, who was very supportive of informal providers and saw them as a political force. There were 90,000 of them in the state, but unfortunately that chief minister died an untimely death in a helicopter crash, and since then the program has been suspended, but the associations are still lobbying, and they do believe that they will get this resumed. So just a few conclusions are that they are all informal providers, maybe on the margins, not recognized by the formal establishment, but they are definitely there, and they are institutionalized by the public, and they are already providing some kind of universal health coverage. And they will continue doing this until the health needs of the people at that level are met in a systematic way through well thought through strategies. But the markets are very different everywhere and need to be addressed in all their uniqueness. Next. So this really is my final slide, just a few issues for further discussion around quality, drugs, incentives. And with that, thank you very much. And I hand over to the next panelist, that is Amanda.
Amanda, do be sure to unmute your microphone, please.
Sorry. Okay, so next slide, please. All right, so I'm presenting today on some DHS analysis I did with my colleagues at JSI and USAID. You can go to the next slide. What spurred us to look at this is continued interest in engaging the private sector, particularly around delivery care, and this is something that David touched on already, to fill some of the gaps in care in low and middle income countries. As he's already mentioned, there's some concerns around the quality of care that be supplied by these providers. Particularly for delivery care, there's been some concern that there's over-provision of cesarean section or under-provision of other essential components of that care. We hypothesized that the private sector would be competing for clients on perceived quality, so they would actually be providing or trying to provide the image of quality care for delivery, and therefore their clientele would be wealthier and more educated and probably be living in a population-dense area where there would be competition amongst providers. Next slide, please. We focused on the Asian region, and we looked at 6 countries where USAID provides maternal and child health funding, and we asked, from the data that we have, can we see if private sector delivery care has increased over the period from 1999 to 2009? And if it has increased, how has it added to overall growth in facility deliveries? If it doesn't, is it replacing other forms of facility delivery? So this is something, again, that's been touched on in some of the other presentations. Is it actually improving coverage of facility delivery, or is it just competing with the existing forms of facility delivery? And finally, we wanted to know who is using private sector delivery care to look at some of these issues of equity. Next slide, please. So from the region that we were looking at, there were 6 countries that had DHS surveys in rounds 4 and 5, which touch upon the 1999, 2000 threshold, and then up to the 2009 threshold. Bangladesh, Cambodia, India, Indonesia, Nepal, and the Philippines, and you've heard about some of them already in some of the other presentations. Next slide. I won't go too deeply into the methods, you can see them in the paper, but we tried to follow a theoretical framework on what would help with the decision of where to deliver. So we know that there are both individual and household health system determinants. For the DHS data, we can really only look at the individual side determinants, and amongst those we looked at sociodemographics. We also included measures of economic, social, and physical access, so this is also distance to facility, wealth of the household, and then some social aspects such as women's decision-making. Finally, we wanted to look at some of the measures of actual or perceived need, and this goes to whether it's the first birth, whether there was a previous death of a child in delivery that might spur a woman to look for higher quality or a facility, a higher quality facility for delivery. We did both descriptive trends over the 2 years to look at changes in the different types of facility births, and we also did a regression model using a Heckman selection model to correct for self-selection into the facilities. And this runs 2 models. The first is whether the woman delivers at home or in a facility, and then conditional on choosing a facility, whether they deliver in a private facility or a public facility. We excluded NGOs from the regression analysis because of the heterogeneity in that population, and in some countries there was not enough of a sample to include them. So in answering these research questions, the first is, has there been an increase? Well, as you've already heard, there has been. Overall, there was an increase in facility delivery care in all of the countries and an increase in private sector delivery. When we did this in the regression analysis, 5 of the 6 countries had a significant increase in private sector delivery care. Only Bangladesh did not see a significant change, though there was an increase there. On average, if you look at the change, it was about a doubling of private sector delivery care. And in the last year of data that we looked at, Indonesia had the highest rate of private sector delivery with about 36% of births taking place there. The Philippines and India were around 15 to 20%, Bangladesh 7%, and then Cambodia and Nepal were still quite low, below 5%. Next slide, please. So we know that it's increased. Did it add to growth in overall facility delivery care, or did it replace other forms? Well, it did not replace, it added to, and in no country did the public sector delivery care go down as private sector delivery care went up. So there was no replacement there. And in Bangladesh, Indonesia, India, and the Philippines, the increase in overall facility births was driven primarily by that growth in private sector delivery care. So echoing what we heard from David's presentation, the expansion was in overall capacity for delivery care, which could have a potential positive effect on overall care in this area. Nepal and Cambodia, we didn't see switching, but it was just that the public sector growth outstripped private sector growth in that time period. Next slide, please. So who is using private sector delivery care? Did we see a strong trend across these countries? Well, no. It was quite heterogeneous, and this goes to some of what Meenakshi was presenting. We had assumed that at the point of delivery care, you would be having a fairly trained group of providers in the private sector, even though it's still unregulated in some of these countries. But the only consistent predictor of use was previous use of private sector delivery care, and there's many potential reasons for this, whether it was preferences or payment options, location, but that was the only consistent predictor. In about 4 of the 6 countries, we did see that wealth was a driver of use, and then in a different set of 4, we also saw that higher education was also a predictor, but it was not as strong of a trend as you would expect. And urban residents did not seem to have a strong effect at all. In one country, it did predict, in one country it actually predicted public sector use. So that idea of competition was not borne out in that particular indicator. A few of the need indicators were significant, but not nearly as much as we would have expected. Really the only one that had any predictive power was the prima parity. Next slide, please. And so again, I'm not going to go into some of the other findings we had in here for the sake of time, but going back to Meenakshi's point, we did go back and look at who is actually providing delivery care to try to explain some of this heterogeneity. And you do see that there's still unskilled attendants providing delivery care in private sector clinics, at least in the years of data that we were looking at. So it's something to consider. Anyway, so to sum up, key messages. There was obviously a significant trend upward in all facility delivery care, and especially private sector delivery in the last decade in these 6 countries. In Bangladesh, Indonesia, India, and the Philippines, this growth was driven primarily by private sector, and so there's an overall public good in the increase of delivery care, assuming the quality is acceptable. Wealth and education do seem to be related to this type of delivery care in about half of the countries, just over half, but it's not as universally as related as one would expect, and the other results were mixed. And I think what the key takeaway from this paper is that more work needs to be done in each of these countries to look at what constitutes private sector delivery care in each different context and what drives women to use these facilities. We can't start making generalizations just yet about what is going on in the private sector in terms of delivery care. Thank you very much. I'm going to turn over to Birger to do the question and answer session.
Thank you very much, all. Those were really excellent presentations. I realized it was tough to keep the very strict timeline, but you really did well. Thanks a lot. Just a quick summary of a pretty broad set of presentations. But we've seen that the private sector has grown in Asia. We have seen from David's paper that it had apparently from 2 countries at least it didn't increase inequity. We've seen from India, Meenakshi's paper, that the poor use informal providers significantly a lot, and there were also details on what the providers do, the informal, and they seem to have better knowledge than maybe what we would predict. And then we saw from Zambia that the private sector didn't do worse than the public. Both of them had some shortcomings when it came to counseling. And then from Kenya, we had a presentation by Lucy showing that vouchers can be beneficial in expanding access to delivery services. So by that, I'd like to invite anyone attending here to ask question, comment, or any other type of intervention that fits with this format. And as I said initially, you can write your questions, or you can raise your little hand in your panel there on the board, and I will then give you the voice. So welcome anyone who is out there with your comments. And while we wait for that, maybe I can ask Lucy a question. Yeah, scaling up was one of the issues that you brought up from your pilots. So say, what would you think are requirements for scaling up voucher systems, for instance, in the Asian countries, which we just heard about? So Lucy, please.
Sorry, Birger, do you want to take that again?
Okay. No, I wanted just to ask you simply, what would you say are conditions for scaling up the intervention that you evaluated in your paper?
Oh, the key one that I mentioned was the working within the broader health system context and having both supply, not just focusing on the demand side, but having both supply side and demand side approaches.
And what does that mean in concrete terms? What would you say supply side approaches are?
So supply side approaches, sorry? So supply side approaches for here, I meant increasing the geographical coverage of health facilities. So we can have more facilities that can offer the service, as well as broadening the scope of coverage of the program in terms of the number of the geographical region within which the voucher program is implemented. So that way we have more clients coming in. And then the other thing would be just pushing towards increasing both, not just the uptake of the voucher services, but also the redemption, so that people don't just buy the voucher as insurance, but they're buying it and actually using it to access care. And then the other thing would be around targeting, to make sure that we are actually reaching that new client who would otherwise not have used facility for delivery. You know, a client who previously did not use a health center or a health facility for delivery services, so that then we are bringing in new clients and not just shifting clients from, say, private to public facilities. In Uganda, it's largely private, and that's why we're talking about increasing geographical coverage and increasing coverage to include contracting of public health, public facilities which have a wider geographical spread.
Okay, thank you very much. Any further comments on that? Well, how about voucher systems in Nepal and Bangladesh, David? Do you have any information and any ideas about their feasibility?
Voucher systems are quite prevalent, I believe, in Bangladesh, and I'm not quite sure about the extent to which they're being implemented in Nepal. Although I do understand, as part of the delivery policy, women are receiving some payments in order to deliver in private facilities. So that is administratively can be cumbersome, but probably much more feasible in urban areas than in rural areas. But I think that's an issue that probably needs to be further investigated. I believe there has been a lot of research in Bangladesh. I'm not sure about the amount to which it's been investigated in Nepal.
Meenakshi, you are very familiar with the South Asian context. What do you say about the feasibility of vouchers in South Asia? Meenakshi? Yes, there you go.
Yes, I'm here.
Yeah, I know.
Yes, I think that, of course, any scheme is as good as, can you hear me?
Yes.
So I'm saying that any scheme is as good as its implementation, and yes, it can function very well, but the supply side has to exist, in a way that meets people's health needs. Now, if you are providing vouchers to, say, a rural population to go to the nearest town and access qualified private practitioners over there, it's not going to work so well. But if the government or some other agency is able to kind of engage with the first level providers who are providing basic health care and then integrate voucher schemes with that health care, I think the results will be much more there to see, visible, and it will be useful to the people.
Okay, thank you. And Ilana, I'd like to ask you what, if you have sort of after this work, which was done some years ago, if you have further follow your own recommendations to do more research in this area of work.
Yeah, I mean, I think that, well, I guess I have two comments. I think overall, and we saw this in the 2013 symposium, and I'm excited for the next supplement that will come out. I think that there has been a lot more systematic research about quality in the private sector. I think that people understand that it's highly context specific. It can vary very much by type of health service provided, but you know, these sort of generalizations that we've heard for so long about quality being worse or better in the private for-profit sector tends to just not be accurate and very difficult to generalize. So since then, I think, you know, done some interesting similar kinds of comparative studies in Malawi and Uganda, as well as some research in South Africa, where we just see those similar trends of just huge amounts of variance on quality indicators. The other thing that I would add is one of the factors that made these results in Zambia at the time really interesting was the fact that private providers in Zambia had not been tapped by the government at all, or by donors and non-governmental organizations for training or skills building. So it was interesting to be able to see them perform on par with the other sectors, both the good and the bad, without having been incorporated. And I think since that time, over the last 4 to 5 years, you've seen a huge increase, particularly in Africa, in private for-profit providers being tapped by governments, by being included in some donor-funded trainings, as being sort of holistically considered as necessary recipients of capacity building efforts. So I think that that's a nice trend and advancement from what we saw 5 years ago.
Okay, thanks, Ilana. Jeff Knesovich is working a lot in the background here with the technical part, and he's also set this up. So he has received a few questions, and we'll read some of them to us now. Please, Jeff.
Thank you, Birger. Yes, we've had a number of questions coming in. Some are quite specific and others more general, so bear with me as I go through several of them. There was one from, let's see, John Townsend was asking a very general question, are there any issues associated with the promotion, protection, and fulfillment of client rights in the private sector that might look different from concerns in the public sector? Rodriguez Fernandez was asking, has there been any analysis looking at economic growth within countries, GDP, and in parallel the growth of the private sector provision as a possible predictor of future trends in utilization? There were a number of comments related to the voucher discussion. One from Victor Ruangabo noted that the demand-side financing, such as the use of vouchers, has been blamed for forging the outputs by many unscrupulous clinic owners in Uganda. What is your experience? So I'm guessing that that's pointed towards Lucy. And indeed another question to Lucy is from Kaniva Muindi, who asked, how objective is the poverty assessment tool in identifying truly destitute women in need of a waiver? We have a number of other questions, but maybe that's enough to keep the conversation going for now.
Thank you very much. Let's give Lucy a chance to answer the voucher questions. Did you get them, Lucy? Lucy. Hello? Lucy, are you there?
Sorry, hi. Yes, I am. So I got two questions, one on fraud and the second one on the poverty assessment tool, on the targeting mechanism. And in the first one, fraud, Murray Stops verified claims. They hired a medical doctor to verify claims before reimbursements were done. And from our evaluation, from our perspective, we would assume that that was done effectively. On the poverty grading tool, this was the program worked with community-based voucher distributors who ideally were expected to know their geographical locations very well. And therefore, one of the things that they did was to go to visit, interview clients, visit households, and grade them across a broad range of questions, including social demographics on where they live, previous access to healthcare services, and then based on this grading, then they were identified or ranked as either poor and therefore qualifying for the voucher or otherwise. So the targeting mechanism, that's basically what happened. They used a poverty grading tool that had a range of questions for which clients or prospective voucher users responded to. But the big thing was using community-based voucher distributors, at least to curb the fraud and to make sure that they're getting the right persons. And this would be, the voucher program has offices within the program sites. So this would be easy for them to verify because they had their own team of community health workers who are going around, on health promotion messaging, doing health behavior change communication and health promotion messaging. Thank you.
Okay, David, are you around to pick up the first two broad questions?
Yeah.
And then we'll end the session after that. Those were like macro questions, really.
I believe those were focusing on rights-based approaches and the role of economic growth in rates of economic growth both in Bangladesh and in Nepal.
Okay, thank you very much. As we said, we should go on with this for an hour, and with just a few minutes over time. And I really like to thank all our panelists. I'd like to thank Jeff Knesowicz who set this all up, and of course, last and foremost, thank all our attendees who were around to listen to this. And I'm sorry we couldn't take all your questions, but at least a few of them were discussed and replied to. So thank you very much, and I wish you all a good rest of the day and tomorrow and so on. Take care.